Hi, I'm Stephen Bruce. I run the Academy of Physical Medicine, and here's 45 minutes of free CPD for you. This is just an example of what we do. We run a free session every month, along with 70 plus hours of live learning with others CPD every year. If you'd like to see more, click the link in the info section below the video, and that'll take you through to our website. Enjoy. It was, I think, exactly a year ago that we had Sarah Tribe and Sandra Harding on the show to talk to us about communications and consent. They're both chartered physios. They have a business called HCPG, and they are experts in communication and consent. But today they're going to be talking about lone working. Now, their business is all about making clinics compliant with the regulations under which we have to work. In particular, in their case, the HCPC, the Health and Care Professions Council. But that is irrelevant to you if you're an osteopath or a chiropractor, because those rules still apply if you're under the regulation of any other legislative body, really. So, without me waffling on any further, let me turn to say hello to Sarah and to Sandra. Great to have you with us. How are you?
Hello. We're very well, thank you. Yeah, it's lovely to be back again. I can't believe how quickly a year's gone.
HCPG briefly. Just give us a quick overview of what HCPG does.
Basically, Sarah and I, as you mentioned, both chartered physios, and really what we say is lots of people have unconscious incompetence. They don't know what they don't know about standards and regulations. We are aiming to make you consciously incompetent so you know what you don't know, and then we're here to help you sort it out so that if anything happens anywhere in your business, you've got a portfolio of evidence that shows that you are compliant around the standards and the regulations. And as you quite rightly said, Stephen, whilst we obviously look at HCPC and CSP, Chartered Society Physio in particular, all the standards and regs fall out of the same healthcare acts. So we all need to be considering these things anyway.
A few years ago, this was during the sort of year or two after the Gulf War, everyone took the mickey out of, I think it was Donald Rumsfeld, because he said there are known knowns and there are unknown knowns and there are unknown unknowns, or we don't even know what it is, we don't know. Yeah. Everyone took the mickey out of him about that, but actually it's perfectly true, isn't it? And it's great to have somebody helping us to find our way around all this regulation. But you're going to talk about lone working today in terms of regulation?
What we're going to do is Sarah and I are going to go through some sort of 5 or 6 key points that we think are really important to consider when you're lone working. So we give people some takeaways to really think about, and then we thought at the end we could do some questions and answers, anyone that comes up in the chat, and anything that we haven't covered or any areas of queries. And so, and lone working, it is under there. Lone working it's basically what Sarah and I are all about, is keeping you, your patients and your staff safe. And obviously lone working is a key part of that.
Well, I hope you don't mind. People will send in questions as we're talking. Can I interrupt you every so often to do questions on the fly, as it were?
You can. It might be that we say we're about to talk about that one, but that's fine. Absolutely. So just come in as we go. Is that?
Right then. Tell us about lone working.
So basically, I'm going to sort of start just saying to people, when people think about lone working, one of the really important things to consider is it's not just about your risk of being attacked, which unfortunately nowadays is on the increase. Just done some violence and aggression training. And what you can find in the violence and aggression training, for the first time I've done it, is it talks about how to defend yourself and what legally is and isn't acceptable, which is a sad reflection on the fact that nowadays many people in healthcare will actually receive abuse in some way. Yeah. So
you just scared us a bit there, Sandra, because you said it's on the increase, which always makes me think, is it reports of violence against lone workers which is on the increase, or is it statistically it is getting worse?
That's the difficulty. I think certainly looking at the statistics on the training we've done, they're higher. But is it that more people are more aware how to complain? And so it's actually being reported more often. And I'm not sure around that. But I think the thing people need to consider is lots of people think about, is it violence? But actually, it's not just about considering your safety from that perspective and from an individual, but it's also the fact that if you lone work and you collapse or a patient collapses, what are you going to do? You need to actually be aware and have a process in place. You could be working in a building where you're lone working within your clinic, but the clinic's in a building and there's other clinics. But have you got a process, an agreed way of what you will do if something happens and how you will raise the alarm? So we want to talk around some of those and little things like, do you triage before you see people? A lot of people have moved to triage. And actually, if you're triaging someone, it may give you a bit of a gut feel around an individual. And one thing that Sarah and I always say is if your gut feel is something doesn't feel quite right, then go with it and be very careful if you're going to consider bringing that person in when you could potentially be lone working. Another thing that people seem to forget about lone working is say, oh, well, I've always got a receptionist. Well, what happens if the receptionist goes home early and well? You are suddenly lone working. So Sarah and I tend to say it is very unlikely that there is not some point at some time when a clinician will not be working alone. Yeah. And so you do need to really consider this, even in a team situation.
It's interesting what you said about gut feeling there, because there have been a number of discussions that we've had about real cases, and so many times when somebody says there's been a complaint or something has gone wrong, the practitioner was just trying to help the patient, but something in their head said there's something odd about this, but they were doing their best to help and they didn't want to stop. But they should perhaps have listened to those little warning voices. Yeah.
I think that's what we would say. Don't ignore those warning voices. I think the whole thing around being a healthcare practitioner is that there is a lot, there's emotion around it, and you do get a feel for certain things, and you do feel those people where the rapport feels better than others. And if you just feel something isn't right, what we would say is just stop and think, is something not right, and what are you going to do? And really look after yourself. So if we explore a little bit more, and I talk a little bit about room design, so let's start with the basics. How often do people actually look at where is the exit in relation to the plinth or the couch? And are you making sure that you keep yourself between the patient and the door? So that if it was in the worst case scenario of an attack, that you could get out, you're not stuck in a room with the door behind the patient and you're in that space. And also, where is the plinth? So often people just put a plinth in a room. Just really think about where have you positioned it? Can you get round it to get out? Or could you potentially be trapped? Because when you've put the patient on the bed, you've then got the plinth between you and the door. And so you're making it difficult in that way. And thinking about the collapse, when I was talking about a collapse, again, if someone collapsed behind the door, how are you going to open the door and get them out? How are you going to get out and summons help? So you need to balance, you weigh up and balance and assess, should a door open outwards? Should a door open inwards? These are things to consider that people don't just think about. They just have a room, put a bed in, and away they go. And so
not straightforward though, is it? Because of course, if I have a patient on a plinth, I need to be around that plinth on all sides of it, front, top, bottom, left and right. So it's impossible to have a door on every side.
It is, but it's about thinking. Could you've got someone to lay on it a different way so that you can get to the other side rather than just where you've placed them. So I think it's kind of having a mindset of always, we do risk assess everything that we do, but it's having that mindset of thinking, if something was to happen here, can I get that patient to safety? Can I get myself to safety? And often we don't just, we go into the space and we use it. We don't actually always think about how are we actually going to use it if things do go wrong.
A moment ago, there is a tendency, I think, for us all to imagine that moving an unconscious body is easy, but anyone who's ever tried it will realise that it's not easy. But there isn't much you can do if a patient who's, putting on their coat or taking off their coat collapses against your door, is there? You've just got to deal with it.
Yeah, and that's what I was saying. Could a door open outwards? You need to weigh that up. Is there potential for a door to open outwards so that you can still close it and you've got the privacy, But if someone did and something happened, could the door open outwards? So it's just making those considerations, particularly if you're designing a clinic or you're moving into a new space and you're going to reconfigure some of the space that you've had. So before I go on to some other bits and pieces, Sarah's going to chat about some of the little points to consider before I talk around devices and various things. So Sarah's going to talk a little bit about more logistics.
Thanks, Sandra. I'm going to talk about management of new patients, really. So we quite often have clinics that go on late, and if you have a male osteo, chiro, physio working in the evening, think about not having any female new patients. Only have patients that you've actually seen before and that you know. And again, vice versa. If you've got females, try not to have male patients. So it's about managing that risk as well. And as Sandra said, triaging. So if you are you decide that you do want to have new patients in the evening, maybe a triage, maybe have a call with them, and maybe chaperones. You could have somebody in as a chaperone. You could have your make sure that your receptionist is around. So it's just thinking about things like that. And also, if you're in the clinic and you are the last one there, and you are leaving at the end of the evening, does somebody know that you've actually left the clinic and are on your way home? Or if you're a sole practitioner, that everybody knows where you are. So if you have a big team, and we work quite a lot with talk to big teams about, is the last person, when they leave, they just get into the habit of contacting, especially by WhatsApp with line manager, but they want to decide it, just to say that they've left the clinic. So that then, if it's on a Friday evening, nobody's then wondering what happened to them. They live alone, don't turn up to work on a Monday. So it's just about thinking about things like that. And actually, the WhatsApp is a really good way just to say, yeah, I'm out, I've locked up and I'm on my way home. If something happens to them on their way home, that's very unfortunate, but it's outside your responsibility as a clinic owner, because that could happen anyway. But if as a clinic owner, you have a duty of care to your staff to make sure that they leave safely.
How is that duty of care enhanced by simply knowing that they have left the building?
Well, it's just making sure that they have left the building, that they haven't gone missing, that they haven't been. I don't know whether you remember Susie Lamplugh, who showed that person around the house on the Friday and lived alone and didn't turn up for work on the Monday, and that's when they put the alert out that she'd gone missing. So it's around just making sure that somebody doesn't go missing. That person has left the clinic safely.
On my part, what it's doing is it's reassuring you, the clinic owner, that the practitioner has got to the end of their day and isn't in trouble in the clinic when they might otherwise. Yeah, thank you.
Yeah, exactly.
Lizzie has asked whether there's anything you would specifically include in this triaging process when you're deciding who to see at the end of the day.
Well, the thing to do is obviously the best thing, the gold standard would be not to have a new patient at the end of the day when you're going to be on your own. But if you just have a conversation with that person, quite often you can pick up things on the phone and just feel, I'm not quite sure about this. I think I'm going to offer this patient a appointment when there's other people around. It's just best to have that initial phone call and just get a sense of what that person may be like. That's what I mean by the triage. It's about so that you've just made contact and you've had some sort of. It's impossible to say, isn't it? Because everybody could be different, but it's just it gives you that sense. It's like if you do a domiciliary visit and you're going out. The same thing applies. If somebody new phones up and says that they want a domiciliary visit, it's about doing that triage. It's about having that phone call. It's about just making sure that you do feel comfortable to go and see that person. And also, on that first appointment, it may be worth taking somebody with you. It might be worth taking a chaperone with you. And again, really important when you've gone on a domiciliary visit, that somebody knows where you are and what time you're due to be back.
Absolutely. Yeah, thank you.
Okay, Sandra, would you like me to just talk about clinical wills?
Yes, that fits in with what you were just saying in view of the Susie Lamplugh, unfortunately.
So So if you are a sole practitioner, it's worth thinking about what would happen to your patients if you were incapacitated. If something happened to you, all of a sudden, you couldn't actually tell your patients you're incapacitated. It's good practice to have another peer who will act as on your behalf, who would contact your patients for you and let them know what has happened and perhaps be able to refer them on to another physiotherapist. So that's worth thinking about, and that's called having a clinical will. If you die in service, then you need to make sure that your solicitor knows that on dealing with your affairs, they are going to have to deal with your business and going to have to deal with those patients and make sure that they are told and that the notes are kept safely and securely. And if you retire, you need to make sure that your notes are always available should the patient wish to request them in the future before those 8 years that you have to keep them for. And you need to make sure that your patients are happy for another physiotherapist, chiro or osteo to have their details in that case. So just sort of other things to think about working alone.
What's the rule for you guys in HCPC? How long do you keep patient records for?
In HCPG, us.
No, in the Health and Care Professionals Council.
HCPC. Yeah. It's 8 years.
8 years. Interestingly, I looked this up for osteopaths and chiropractors, and actually the guidance was less clear than that. We all do it for 8 years or longer if it's a child under 21. It's 8 years from 21 or something, isn't it? But actually, I don't think the rules stipulate. So we're simply following medical legislation rather than anything specific to our own professions. I could be wrong on that.
I think it can take up to 7 years for a court case to be brought, which is where that 8 years comes about. Well, it all came up as a result of the data protection business, because we mustn't keep records longer than is necessary, but of course we maintain that there is a medical requirement to keep them. But when you try to pin down what that requirement is, it's quite difficult. And so simply following the procedure which is adhered to by a doctor, for example, seemed to be the most obvious thing to do. Yeah, the ICO actually states that you can justify not because the patient has a right to be forgotten, and in those notes the ICO states that you can keep them as long as you can justify why you're keeping them, and it would be that in the event of them being requested in any future law or any future medical. So that's the reason why you would keep them. It is a bit blanket because then you keep all of them, but you are allowed to keep them. The ICO states that.
The advice we give, Stephen, is that people have to justify why they've kept them, so that if there was a question, they could explain why they kept, not just I've kept them. They have to understand why they're keeping them and how they're going to keep them. And that's the bit that we reiterate. It is the 8 years, but if you want to go beyond, make sure you've very clearly got a process that you could use to prove why you're doing it the way you're doing it, not you just haven't got round to a process, which is unfortunately what several people do.
Here, isn't it? And it's distracting you from your lone working discussion.
Yeah. So shall I talk a little bit, Stephen, about some devices and things that people can use that when we're talking to, and it's increasingly osteos are joining the training that we're doing with the physios, and people are saying, what can we use? What can we do? Yes, we now get the idea. We need to make sure we'll use WhatsApp or whatever. But there are devices that you can use, the listening devices. And when we've spoken to the CSP about this, they are supportive with us. You can use a listening device to record a session as long as you've risk assessed why. So it could be you're working alone in an evening and you couldn't avoid it because the receptionist has gone off sick or whatever. If you do the recording, that overrides the GDPR rules, but patients must have been informed in their patient information leaflet that you may need to record a session, but you will destroy it immediately afterwards. So the use of listening devices is acceptable as long as the recording is destroyed afterwards. And some of the devices have a keyword, which when you purchase them, if the keyword is spoken, it triggers an alert, which means the emergency services will be sent. If you go on Google,
That's
if you go on Google, we can't promote anyone in particular for all obvious reasons. But if you go on Google, there are quite a lot of listening devices there, and they are in use in some clinics now. And some people have opted for that rather than, we've got individuals we've been talking to who have chosen to have panic alarms that connect to the police. They want to press those. We've also had some individuals who have purchased very loud personal alarms and have, when they're in let's say a shared building, and they've made the others in the building aware that if they hear this, please can they run to their aid, this is their alarm, and they're aware how it sounds. So there's those things, but a simple thing you can use as well is putting on a video entry. So someone rings to get in and you've got a little video entry, so as long as they're not a new patient, you can recognise if the person trying to get in is your patient that you're expecting. So that's something to consider. But one thing we're also suggesting to all therapists is that if you're working, you're coming home alone, or you're in the community, there's an app called What 3 Words, and that will locate you to a 2-metre square. And it's used by the emergency services and can be accessed by the network providers, so that if you do disappear, if you have What 3 Words on your phone and your phone is with you, then that is a quick way for them to track you. And it's supposedly far more precise than the Find My Phone apps that most phones now have. So we tend to say to individuals, if you're in a scenario where you feel you would like to use some devices, these are some things that you can consider. So as there's the listening devices you can look for on the web, there's the alarms which you can link to the another area or to the police. There's the video entry, and then there's the What 3 Words app, which is a useful app to be holding on your phone, just to kind of let people find you if, unfortunately, they have to do that.
Well, we're a great advocate of What 3 Words here, because we do a lot of first aid training. Obvious location at an obvious address. What 3 Words is a brilliant way of getting the emergency services to your location. I wanted to ask you though about, you said that if you have a recording device, a listening device you called it, which you said is recording, why do you have to destroy it straight away as long as the patient knows you've got it? Because actually if they complain 2 weeks later, it would be really handy recording.
Well, the thing is, if you're going to keep it, you would have to state that the recording is going to become part of the clinical record. We are talking about using the device purely for working alone in safety. So here you're just using it so that it's there, so that if you had a concern, you've got it, and it's there in case you feel you want to call for help, and you've got it set up to do so. So if you're going to keep it, you could, but you would have to say you're using a listening device. You'd need to have consent, because then it would become part of the clinical record.
Yeah. And of course, with a lot of those devices, certainly with some of the software that we use, you can automatically create a transcript from it. Yeah. Admittedly, one which will have lots of errors in it, but a transcript, we could create the transcript and just keep the paper record if for some reason recording is deemed to be less suitable.
Yeah, you indeed you could, and I can't tell you which ones will and won't allow that, because as I say, we don't go into looking into all of them. But the important thing is people must be made aware that you've got a device and the purpose you're using it for. And as I say, if you're going to keep it, rather than just having it as a just in case for working alone, then you would need to make sure people have consented to that.
Yeah. Can I just say there, Sandra, as well, that you were talking about the GDPR overrides. Yeah. So in that circumstance, so the patient can't actually not have to agree, because it's part of
health and
safety. But if you were going to save it for other reasons, then the patient would have to be given the opportunity to say no.
Yep.
Yeah. Does that kind of makes sense? Any other bits, Sarah, you want to kind of bring in there before we were going to allow some time for people to ask any more questions? Stephen, if any more have come in.
Oh, yeah, they have, yeah. Sorry, I didn't want to interrupt. I know you said you wanted to get questions at the end, but of course we like to do them as you run through. I've got some more questions here already.
Yeah.
Well, by all means, we've kind of covered some key themes I wanted to talk about. So do you want to have a fire away with some of the questions?
Yeah, sure. Vlad has brought up reflecting on what you said about placing the treatment table in the right place. He said he'd heard that the opposite was best, which is that the treatment table should be closer to the door so that the patient doesn't feel hemmed in, and psychologically they feel that they can get out if they have to.
I think from that point of view, I don't think it matters where you're having the bed. The important thing we're saying is that you can get out from where the bed is. So it may be you've got it near the door, but still make sure you can get out if needs be, and you can get the patient out if something happens, like we've said, the scenario of a collapse.
Yeah, I think his point was that the patient might feel hemmed in if you're between them and the exit from the treatment room. But as I said, it's very difficult to find a way around that, because certainly most osteopaths I know, and probably most chiropractors, will be working all around the table anyway.
Yeah.
Somebody who has been named by our system Toodle Pip says, no, I don't know why it does it, but anyway, I have been told that this is a she, which is very useful. She has an online booking system, hugely popular and easy for patients, which makes it slightly awkward, since patients can book themselves in online at various time slots that suit them, some of which might be their last appointment, 6 or 7 o'clock at night, as a new patient. And she and her husband work together from home, so we wouldn't be alone, but this issue might apply to others.
That's quite possible. Sometimes with some of the online systems, though, you can actually, and I'm assuming she can't, or I don't know whether she's aware if they do this, with some of the systems, you can give visibility of spaces for new patients and spaces for follow-up. And so the system would know you're a new patient and therefore only show you the new patient spaces, which you could set them up as though they're not the ones at the end of the day. I don't know, because obviously different systems work different ways, but if you go back to your software developer or your software provider, it might be quite possible that they could do that. Yeah.
We use Jane in my clinic, and I'm pretty sure that you can say that certain types of appointment aren't available at certain times. But I guess that it's always difficult to predict, isn't it? Because on that day when the receptionist is sick and the other practitioner hasn't got any patients, you find yourself working alone, even if you were even if it was unexpected.
Yeah.
John has said that he had a potential new patient the other week, and he works alone. He suspected the patient of being an alcoholic and was very wary of them coming alone and without a chaperone, but thankfully they failed to show. I'm not sure what advice he's asking on that, but do you have any thoughts?
Sarah, do you want to?
So definitely, the thing is that if you pick that up when they are with you, and it's a new patient and you think they're under the influence of alcohol, you could say that you would rebook it, or, because they're not, so there's something about that, and there's something about chaperones, having those people. All you can do is risk assess as much as you can. Make sure that you, do your risk assessments for your new patients. Those things may happen, but it's so just think about, if that did happen, how would I manage it?
And also, I think, so something there is, if someone is under the influence and you're really concerned, you may be questioning, how are they actually capable of giving consent? So is it better to rebook? Because is this person really understanding, and do they have capacity to agree with what I'm suggesting?
I think John's point was that he suspected they were alcoholic, but wouldn't have known all that until they came into the clinic. And maybe he would have been at less risk than, say, a lone female osteopath or chiropractor, but nevertheless he wouldn't have known until they got in that they were alcoholic and potentially a difficult patient, let's say. Somebody's come back to me, I don't know who this is, about what 3 words. They had a patient who had to call 999 and was asked by the emergency service if they knew what 3 words were, and they now have it written in each of the treatment rooms, which is really useful, isn't it? Because the practitioners might know it, but the patients might not. But to have it written in the treatment rooms is very helpful. And if you're not aware of what 3 words are, it's a simple app that you can download for nothing. It's called the number 3 words, and it gives you a precise location of where you are anywhere pretty much on the globe to within about 2 or 3 meters. And you can test that because you bring it up on your phone and you walk across the room and you'll find you've got a different 3 words. So very, very helpful. And the emergency services are all familiar with it. Now, Kim has said that
I think it's been encouraged as well, Stephen. I think the emergency services are encouraging its wider usage because it has been proved to be so robust.
Yes. Yeah, it takes a lot of the uncertainty out of it. And for them, of course, interestingly enough, I've been out with the emergency services, and even when they've got an address, when they're driving down a street, they don't know which number the house is because they're not always in a logical sequence, but what three words will take them straight there, and they don't have to watch for somebody windmilling in the middle of the street waiting for the ambulance or whatever. Kim says that, I don't know if it's a he or a she, Kim, but Kim worked in a practice that locked the outside door as soon as the patients entered because drug users thought they could get drugs in the practice. Unfortunately, a user got in through a different entrance when Kim was treating a patient. He or she heard a noise, went to investigate, and the patient heard the confrontation with the intruder and got dressed to give support. Kim told the intruder to clear off in no uncertain terms, threatening the police, and he cleared off straight away. But Kim did feel trapped because the door was locked.
Yeah, I think that's a very fair point. Yeah, and I don't think there's any particular way, as you say, round that. If you're going to lock the door for safety, then you are going to have the concern if someone breaks in, then potentially it is going to make you feel less safe. I can completely understand why Kim felt like that. But I don't think the problem's arisen in my own clinic to a certain degree because we can't use the Yale locks on the doors because, for a number of reasons, but we've got a lot of duplicate keys. It's a very old building, but they're really difficult to get all the keys to work in the Yale locks from the outside. So we use the Chubb locks when the clinic is closed, but we have them all unlocked during the day because, of course, we need fire exits, so we can't have the Chubb locks locked. And we've been puzzling over how to resolve this. And someone will say replace the Yale locks, and we have thought about that, but it begs the question of key control and all that sort of stuff. Yeah. So again, it's all part of the risk assessment, isn't it? It is, absolutely. It is. It's all of these things, as you say, you've got to risk assess and decide what is reasonably practical to do to show that you've done as much as you can to make things as safe as you can. But Sarah and I, we're always saying to people, what we've got to remember is we're humans treating humans. It's not baked bean can on a production line, so occasionally things will happen, however much you risk assess and however much you put in place. And this is why the lone working is so important, because things will still happen, as you can see from the examples that you've raised already.
And that's a really good time, isn't it, Sandra, to do an adverse events? Do your adverse events, do your document it, and then do your learning cycle and think, actually, what can I put in place now to decrease the risk of that happening again and trying to close the loop. I mean, it's really unfortunate if those things happen, and I do feel for those people. It's horrible, but then it does make you think, actually, so that happened, so what do I need to put in place now to really try and prevent that from happening again?
Yeah, I think that's very sound, is making sure that you actually do take some action when something goes wrong, or even if just a possibility occurs to you during the course of the day, rather than waiting for the problem to actually occur. But I suspect that a lot of osteopaths, chiropractors and physiotherapists, when they hear the words risk assessment, the shutters will come down, because I think, oh my God, that's some great bureaucratic form that I don't understand, and I don't have a copy of, and I don't know what I've got to cover. And genuinely, a lot of people will just say it's too difficult, put it onto the maybe do next week pile, and that's where it stays forever. Is there a standard template that you can recommend for risk assessments?
We do have a template. What we say to people is it's a simple template that we've created, and we always say use a risk matrix, score before, put things in place, score after, so that you can show that you've made a difference. And actually, if you're wanting a lot more info, the Health and Safety Executive website is actually very good and does have templates, and in some areas they are healthcare specific. So it's well worth having a look on there. Otherwise, we'll share our website address and things at the end, and people can go and have an explore in our store, which we didn't have when we saw you last time, and there's lots of things in there that people can pick up.
Right. Okay. Nita's sent in a question. Have you considered the process of people having to sign in to the clinic with a system which can be monitored by someone else? So when patients arrive, they have to sign out. I think it's when they arrive, they sign in. When they leave, they sign out. And it's apparently used at GP practices so they can monitor who's in or out of the rooms there.
Oh, you mean, so you can have a board. I mean, some clinics will have a board where there's names, and you basically slide the board when you're in, you slide the board when you're out. Obviously, if there's a fire incident, then you need something, because whoever's your responsible individual and your fire marshal needs to know who was in the building, and they need to know if someone's nipped out for a coffee or not, because obviously you could be going back to look for someone who isn't actually there. So you need, under your fire point of view, you need a process, and yes, you use the same system to see if people are in or out when they're working, but we're more concerned about when it's just that last person at the end of the day. What is the process for them to make sure they've safely got home?
Do you know, I'm always a little bit suspicious about those fire processes, because it's all very well saying that we sign in or sign out, or you've got a tally that you put somewhere, but we all know that in reality, people, if they want to go for a coffee, will just go for a coffee, and they're not going to remember to do that. But as you say, you've got to think about the risks and think about the processes. A final question for you then. Chris has said, what about mobile phones? A colleague of Chris's got adverts about a topic they'd spoken about together in the clinic room. Presumably her phone would have heard anything that a patient said as well. How does that work with GDPR? I'm not quite sure what the connection is there. I think he's just questioning, what about phones that are listening in to what's being said in a treatment room? Chris, perhaps you could just elaborate a little bit on that. Are you worried that phones are listening in even when they've not been told to listen in? Or are you worried that a patient might be secretly recording what goes on in the treatment room? I'm not entirely sure about the thrust there. But again, do you have concerns about mobile phones in treatment rooms, Sandra?
We've not had concerns raised about mobile phones in treatment rooms. I think several clinics just basically have a notice to say, please, can you switch the mobile phone off while you're in having treatment, just so that it's not an interruption. I mean, you can ask, but you still don't know if an individual has got a phone on and has left a phone on.
There's a big difference between switching a phone off and having it on silent, though, which is what people would infer from that. They would assume you meant put it on silent.
Yeah, I think if I was treating someone and I was to see they wanted to put their phone on the side, I'd be thinking, why do you need your phone out, visible? Are you planning to try and record something? And coming back to that gut feel, if there's these kind of things happening, I'd be thinking, what is happening here? Why does someone feel the need to do this? So as opposed to someone who's got the phone, put it out of the way, it's in the bag, and less likely. But as you say, I'm not quite sure which tack Chris was taking there with his question. I'm not
sure where the law stands on this, because frankly I wouldn't give a damn if someone was recording my treatment, because if I'm doing anything that shouldn't be recorded, then I shouldn't be in practice.
Exactly.
But again, the law might stipulate that if they want to record me, then they have to ask my permission, just as I would to record them.
Yes, because they'd need your consent. Yeah.
Any final thoughts? I mean, what can you at HCPG offer the people who are watching today in terms of support, Sandra?
Well, what we can do is we can help you with your policies. That's all available. If you go on www.hcpg.co.uk, you can see our store, and we have policies in there where we will sit with you, talk you through the policy, talk you through how you set one, how you create it, talk you through some of the things we've talked through now. What would your process look like in your clinic, so that you can personalise that policy? What we always say to people is, don't cut and paste someone else's policy, because if you don't understand it and you haven't gone into the depth and you haven't had the research, if something happens, that's when you'll fall over, because someone will investigate and discover that you didn't actually know what you were doing. So we're very happy to support people, to go through policies with them, and we also do some lone working training as part of a setting up in private practice or a compliance refresher course, which is very popular, that we run on a monthly basis. So we offer the policies, we'll offer the support, or if people just need a quick call, we also have a book a call facility on the website as well.
Okay. Well, that's reassuring. What about, can I just, this is a final question, I have to be fairly quick, I think. What would you advise to someone who's taking up an associate position in someone else's practice about what they should be looking for, and how far they should press their case if they think that the procedures are not what they should.
Any individual signs up to their registered body to say that they are adhering to the standards. So any individual has a personal responsibility to adhere to the standards, whether they're the clinic manager, whether an associate, whatever. But if you're going into a practice and as part of your working in the practice you're adhering to their policies, then if their policies don't exist, you do need to raise a query, because that would mean your own professional registration, you aren't adhering to the standards. And it isn't a cop-out to be able to say, oh, well, I thought my boss had to do it and they haven't got them. Everyone is individually responsible.
Okay. Sandra and Sarah, thank you very much for giving up your time this lunchtime. Hopefully it won't be, I want to get you in the studio next time rather than do this via the horrible team links.
Yeah.
It would be so much more fun, and it would be a much more enjoyable experience for all of us. And I hope it won't be a year from now. It's almost exactly a year since you were in last time. It was the 7th of April last time. But next time, let's make it a little bit sooner, and let's get you in the studio and we'll have another great time. But thank you so much for your time. Thanks for your expertise. We'll put up your website details. I'll send those out, and hopefully you've helped out a lot of people with what you said today.
Lovely. Thank you very much.
Thank you very much.
You're very welcome. It's been our pleasure.